Hello, everyone. Am I audible?
Yes, madam.
Very good. Did anyone here in this class have any ECG sessions with me? Okay. Very good, very good. I'm good. Okay, good. Let's start with a new session of ECG. Here's a question. You are called to the home of a 62-year-old male who began experiencing substernal chest pain while shoveling the snow. He rates the pain as 8 on a scale of 1 to 10. He's slightly diaphoretic, blood pressure 154/88. His pulse rate is 100. Pulse oximeter is 98% on room air. He has no past medical history. Question. You quickly obtain an IV access, complete a 12-lead ECG. This is the ECG. What is the diagnosis? Inferior wall infarction, normal ECG, lateral wall infarction, anterior wall infarction. Very good. Mostly are saying inferior wall infarction. When we say inferior, which leads do we mean exactly? Very good. Yes, we're talking about leads 2, 3, and AVF. So as you can see here in leads 2, 3, and AVF, you have ST segment elevation. Leads 2, 3, and AVF, they are called the inferior leads. They show you the inferior part of the heart, which is partly on the right side. Other leads, leads V1, V2 show the anterior wall. Leads V3 and V4 show the septum between the two ventricles, and leads V5, V6, 1, and AVL, they show the lateral wall, which is mostly the left ventricle. Fine. Another question within this question, you've got a diagnosis of STEMI. Not all the infarctions are STEMI. You have also non-STEMIs too, means the ECG changes are non-specific changes like ST segment depression or T-wave inversion, but your troponin is positive, which means you had the infarction, which means heart cells died, burst open, and enzymes within the cells now are in the blood. That's why you can trace them. Very good. So the diagnosis would be inferior wall infarction. So what do you do for this patient? Treatment. A, MONA plus PCI. B, MONA, check the troponin, wait, but decide based on the troponin. C, MONA, thrombolytics. D, just MONA. Let's check the history one more time.
A option, mono plus PCI.
Mm-hmm. Anyone else? Very good. Mona and PCI. So why do you don't wait for the troponin result?
Normally, troponin results will take 4 hours to come. And
Mm-hmm.
by that time, the infarction will cause the damage to the heart.
Okay, fine. But why in ST segment depression then you wait for the troponin result?
To,
That
different,
also takes 4 hours?
to differentiate between infarction and ischemia. I mean, if it is
Very nice. Very nice. Perfect. Perfect answer. Very nice. So technically in the heart pains, in the anginas, you have 4 different concepts. One is a stable angina. Stable angina means the patient tells you, when I walk, when I do some physical activity, I have the pain. When I don't, no pain. Or when I sit down, the pain goes away. That is called stable angina. In a stable angina, most of the times the ECG is normal, no changes. In 2 scenarios here, you have non-specific ECG changes, like ST segment depressions and T-wave inversions, or peaked called T-wave, hyperacute T-waves. One of them is called unstable angina. One of them is called a non-STEMI. An unstable angina is that your patient has a little hypoxia in the heart because of some obstruction in the coronary arteries. But the hypoxia wasn't that much to cause muscle cell damage, permanent damages. So because of the hypoxia, you have some changes, but it wasn't enough to make the muscle cells die and burst open. So because of that, the troponin is negative. But in non-STEMI, you have the same ECG, the same pain, but troponin is positive. It means some cells have died. You have some severe ischemia and infarction. So in this, troponin would be positive. Why do we have to differentiate between these two? Because the management is different. It's just unstable angina. It's not urgent. You actually can control the pain and send the patient off to a cardiologist. They usually do an angiogram to see where is the obstruction, where is the plaque, and what they can do about it. But a non-STEMI, a troponin positive, it's urgent. You have to keep the patient. The patient had an infarction. It may later turn to an STEMI. So you have to keep the patient. If your patient is high risk, we will send the patient directly to PCI, and you have to keep the patient. And STEMI, you know what is going on in the STEMI. When you have an STEMI, means you have transmural infarction, which means if not the first time, in the second time, the troponin is going to be positive anyway. So why waste the time? It's going to be positive. Not now, 4 hours from now, it's going to be positive. So do not waste the time in STEMI. Give the patient Mona, and after that, you can send the patient for PCI if PCI is available within 90 to 120 minutes. Nowadays, most of the textbook says 120 minutes from the time of the patient's arrival. From the time of the patient's arrival to your clinic or any other facility. Let's say you're working in a clinic. A patient comes to you. There is, with the same chest pain, you do ECG, there is ST segment elevation. There's a hospital half an hour away from you that has cath lab. So what do? You give them Mona, you escort the patient to that hospital to do PCI. But if PCI is not available within 90 to 120 minutes, your next option would be thrombolytics. Of course, when you do thrombolytics, you have to make sure there is no contraindications. There is a long list of contraindications, absolute and relative contraindications. You have to make sure there is no contraindication because thrombolytics, technically, you can tell by the name. They do lysis on any thrombus. Technically means your blood doesn't clot. So if your patient had a history of brain hemorrhage, it may start hemorrhage again. If your patient has any active hemorrhage now, any traumas, it may start bleeding so much that your patient dies. So thrombolytic is a drug that you're giving the patient to ensure their cardiac flow. But don't kill the patient while doing that. So check there's a long list of contraindications, check the contraindications. If not, you have to give it, but there is also a time limit. Thrombolytics should be done within 30 minutes. Start of the thrombolytics should be done within 30 minutes of the patient's arrival. This is called door to needle time. This is 90 to 120 minutes called door to balloon time. So yes, for this patient, you have an STEMI. STEMI means troponin is going to be positive anyway, so there is no need to wait. Of course, you will send, but you do not wait. You start the treatment, you send the patient for PCI right away. Very good. So let's talk about Mona a little bit. We talk about Mona. You always hear Mona a lot. Very good. Mona. What is Mona?
Morphine, oxygen, nitrate,
And aspirin.
And
aspirin,
not only
Aspirin.
aspirin, antiplatelet therapy. Antiplatelet, not only aspirin, because antiplatelet therapy is not only aspirin. You know, the loading doses of antiplatelet is 3 drugs. 1, morphine. How much is the dosage?
Minimum 4 milligram.
Yeah, you go 3 to 5 milligram. You start 3 to 5 milligram. You can titrate based on the patient's response. And you also have to give the patient antiemetics because as patients, most of the patients, after you give them opioids, they're going to vomit. Oxygen, you give the patient with nasal cannula or mask or any other thing that you have if O2 saturation less than 92% or the patient feels breathless. Okay, so if O2 saturation normal, you ask the patient, Do you have shortness of breath patients? No, my breath is fine. There is no need for that. Nitroglycerin, you can use the spray, you can use tablets up to 3 times. The tablets or the sublingual spray you can use up to 3 times with 5 minutes difference. It controls the blood pressure. It dilates the venous system, helps with the pain. But there are contraindications to give the patient nitroglycerin. So to which of these patients you can easily give nitroglycerin? A,
ST elevation MI.
sildenafil. B, patient has a blood pressure of 110/50. C, patient with inferior wall MI. D, patient with severe headache. And E, patient with renal impairment. To which of these patients you will give nitroglycerin?
See, sildenafil is contraindicated because it will cause hypotension. RV inferior wall MI, there is a contraindication because it is associated with RV MI, hypotension again. And renal impairment we can give.
Very good, very good. Yes. Sildenafil, contraindicated for the last 48 hours. If your patient took sildenafil for the last 48 hours, it's contraindicated. Low blood pressure, contraindicated. Inferior wall MI is not contraindicated. It's not a contraindication for giving the patient nitroglycerin, but you should be careful. Because there is a, if your patient has a right ventricle problem, there is a good chance that when you give the patient nitroglycerin, you're gonna have a sudden drop in blood pressure. Severe headache is also not a contraindication, but a very, very common complication of nitroglycerin is severe headache. So that pain might be problematic, but renal impairment, there is no problem because nitroglycerin is primarily metabolized by liver. So renal impairment does not matter to us. And antiplatelet agents, you go for aspirin, you go for clopidogrel or any other second antiplatelet agent, and you go for atorvastatin. Clear? Clear?
Yes, ma'am.
Very good. So now let's go to another question on the same ECG. Except and STEMI, there are 2 other problems in this ECG. Anyone can tell me?
AV block, ma'am.
AV block. Which type?
First degree.
Yeah, 1 second. Let me see. First degree.
Oh.
Fine. Yeah. There is first degree heart block. You can see PR interval clearly long.
Increasing.
Anything else? Okay, so tell me something. This PR interval, is it the same as this PR interval?
It's slowly increasing and
Yes, as you can see, you have 1P. The first PR is long. This is your first degree heart block. But the second one is even longer. The third one even longer. The fourth one even longer, right? So you have a P, you have a QRP, you have a QRS, you have a T. So what is this one?
It's a drop.
Type 1, ma'am.
Yeah, it's a drop. So as you can see, you have an increased PR interval plus and gradually increasing PR interval. Fine, so what is this? AV node block type?
First degree.
Type
Type 2.
Means,
Type 2 second degree AV block.
mode, it's type 2.
Second degree type 1. Here are the differences.
Yes.
If you have only the first degree, you only have increased PR interval, but it's regular, everything is
Regular.
normal except this. In the second degree, you have dropped beats, means you have unconducted P waves. Okay, first degree is not like that. You have prolonged PR interval, but all the P's are conducted. Second degree, you have dropped beats. It means there are some P's that are not conducted. If these P's, they are regular, it means you have gradually increasing PR until one is dropped, one beat is dropped. That is called second degree type 1. It's foreseeable, it's predictable. But type 2, it's the same thing. You have dropped beats, but unforeseeable, unpredictable. There is no regularity in that. You may have any other problems. You may have first degree or second degree type 1, but suddenly, or even normal PR interval, but suddenly there is some P's that are not conducted out of any orders. That is called second degree type 2. And the third one is, of course, third degree or complete heart block, which means P waves are on their own and QRSs are on their own. So here, which type do you have?
type 1 second degree. First degree.
No.
I mean type 1 second degree.
It's type.
Fine. So your patient has
Hello.
an
Excuse
Yes.
me, I was out of the content. There was some disturbance. I have seen the ECG right now. This is the inferior wall MI with progressing. This is a second degree, this AV block.
second degree type 1, yes. Fine. So you send the patient, you give the patient Mona, you send the patient for PCI. What do you do about the block?
See, basically, we will do the temporary pacemaker simultaneously. Once the patient will be in the cath lab, the cardiologist will put the temporary pacemaker, and simultaneously he will do the PCI only, followed by the PCI.
Anyone
If we-
else has any idea?
If we have did the thrombolysis, so either you can do external pacing also for prophylaxis.
This-
Mhm.
This patient is symptomatic with type 2 block. So first we would prefer with CPR.
No need of CPR.
Patient
So
is
this patient is alert, awake, sitting there talking to you, blood pressure 144/88, pulse rate 102.
Yeah.
yes.
What's the PR? Patient is talking to you.
See, only for the prophylaxis, only we can put the temporary pacing followed by thrombolysis or PCI. Because
Why
inferior
do you
wall is always associated, maximum time is associated with the blocks. And once after the revascularization, it reverts to the normal rhythm.
So here's the thing.
No need of treatment. Inferior MI
External
right
pacing,
coronary artery supplies same SA node also.
Okay.
Once the
Here's the thing. If because of the block, let's say complete heart block, or second degree type 2 or anything else, your patient has problem in the perfusion. Patient is in shock, severe bradycardia, yeah, go do the pace. But this patient is sitting there talking to you, the heart is beating 102. Why do you need the pacemaker for? It is making its own pace. Yeah, so you know that inferior wall MI, so this is your heart, it's lying like this. This is the SA node, this is the AV node. So in inferior wall MI, having AF, having AV node blocks is common. So it depends technically on which type of the block we are talking about. If it's only first degree, second degree type 2, type 1. There is no need for the treatment. Direct treatment of the block. They came from ischemia. So treat the ischemia and watch the patient, make sure they don't develop any higher degree blocks, and just watch them until they become until the PR interval becomes normal. Meanwhile, make sure your patient doesn't have any electrolyte imbalances or any other problems. But complete heart block is different. Your patient mostly has bradycardia, they have Stokes-Adams. So for that, you need pacemaker. Second degree type 2 is also dangerous because it's not predictable, it's not unforeseeable. Because of that, you may have to keep a close eye on the patient, but there is no need for urgent pacemaker. Urgent pacemaker will for complete heart block. Otherwise, for type 1 and second degree type 1 and first degree, absolutely there is no need for you to do anything directly for the block, just treat the ischemia. Is it clear? Yes?
Yes.
Very good. Next. Nine-year-old woman brought into the hospital in the outpatient clinic. She says that she feels weak and slightly dizzy. Blood pressure 77/34. Heart rate something between 132 and 159. This is the ECG. What is the best treatment? Digoxin, defibrillation. I'm sorry, this is synchronized. Synchronized cardioversion or diltiazem. Defibrillation and unsynchronized cardioversion are the same thing. Defibrillation, synchronized cardioversion or diltiazem.
Can you repeat the question, please?
Sure, we're going to go back to the question now. This is the question.
What is the hospital outpatient CBC fees? We can design 74, 34, okay. Understand, madam. Understand. Is the atrial fibrillation?
Yeah, what do you do?
We will do the unsynchronized cardioversion. I don't know the options. What are the options?
So I'm going to give you a hint for any question. You have.
Sorry.
You have like two sorts of cardioversion. You have synchronized cardioversion. You have unsynchronized cardioversion, or
Yeah.
otherwise called as defibrillation.
In this scenario, we will do unsynchronized.
This one, synchronized, is always for the patient
Conscious.
with pulse, not conscious, no,
Okay, pulse.
with pulse. This is always
Pulseless.
for the pulseless patients. But don't make a mistake. I'm not telling all the pulseless patients needs defibrillation or all the patients with pulse need synchronized cardioversion. I'm saying that in a pulseless patient, do not give a synchronized cardioversion. And in a patient with pulse, never give an unsynchronized cardioversion or defibrillation. Is it clear? Technically, to make it easier for you, when you say synchronized, it means being synced with something. What is that thing? That thing is the patient's pulse.
Pulse.
So when you say synchronized, means there is a pulse, I'm going to get synced with the pulse. But when you say unsynchronized, means there is no pulse, there is nothing to be synced with. You understand?
Yes, ma'am.
Yep, very good. So when the patient is sitting there talking to you, or even patient unconscious, but there is a palpable pulse, the answer is never unsynchronized cardioversion unless your patient loses the pulse. You understand?
Yes.
Very good. So here's the thing. Most of the times, when you see something like this, you get caught up in figuring out what is this rhythm. I've seen in the chat box, people say SVT, some other people say AF. It doesn't matter. It's a good thing. It's a very, very good thing that in the algorithm of the management of narrow complex tachycardias, it actually does not at all matter what it is. The management does not have anything to do with what is the name of the rhythm. It actually just works with a few simple questions. Anyone could answer that. So just one more time, I'm telling you, when you see any tachycardia, narrow complex, broad complex, do not get caught in what is the name of this rhythm. That actually makes you do some mistakes. Why? Here's the thing. The first question in any tachycardia, any abnormal tachycardia, I don't mean sinus tachycardia. In any tachycardia, which is a narrow complex, can you tell me some examples of narrow complex tachycardia? Some names.
Supraventricular
SVT.
tachycardia, AVNRT.
Yeah, here's the thing. AVNRT. Let me tell you something. All the narrow complex tachycardias are coming from above the ventricle. Hence, all of them are called supraventricular tachycardia. What does supraventricular mean? It means it's coming from above the ventricles. It's coming from above the AV node. Okay? So supraventricular tachycardia technically means narrow complex tachycardia. Okay? One of them, AVNRT. Anything else?
Atrial
AF
fibrillation.
phase.
AF, very
A-
good. Yes, AF is also a narrow complex tachycardia. Anything else?
Flutter.
Wenckebach's phenomenon.
Atrial flutter. What?
Wenckebach's phenomenon is broad complex.
No, those are blocks. We're talking about tachycardias.
And
Blocks are like different
WPW
concept.
syndrome.
Okay, so here's the thing. The main are AVNRT, AF, and atrial flutter. Okay, so here's the thing. The first question, whenever you see a narrow complex tachycardia, is this: is the patient stable? Yes or no? This completely separates your way if your patient is stable or unstable. What do I mean by stable or unstable?
Pulse.
Blood.
No, we're talking about people with pulse.
Okay,
People without pulse, you go directly to CPR. We're talking about people with pulse.
consciousness, blood pressure,
One.
and
BP.
cardiac.
Patient is in shock or no?
Sure. Yes.
Low. 2, patient has syncope or no? Three, patient has chest pain or ischemia on ECG. Anything else? Anyone else?
Breathlessness, ma'am.
No, breathlessness is not considered. Technically not breathlessness itself, cardiac failure. Cardiac failure is considered an adverse sign. Okay. So if you an acute heart failure, not that the patient tells you I'm a case of congestive heart failure for 5 years, not that, acute heart failure. If the patient has that, means your patient is these 4 we call adverse signs. If your patient has those, patient's called unstable. So what do? You seek expert help. You sedate the patient. And you give synchronized cardioversion. Why? Because your patient is unstable. Patient is in acute heart failure. Patient is in shock, syncope, loss of consciousness. Patient is dying right now. There's no time to lose, no time to waste. Just give the patient shock. That is what you do. And of course, after that, you have to check the patient's electrolytes. You can give the patient amiodarone and that. But what if the patient doesn't have any of these? Patient is stable. What is the next question? The next question is that, is it regular or no? Is the rhythm regular or no? If it's not regular, it's probably AF. Okay? So what do you do? Nothing. Go treat as AF. Patient is stable. There is no run. There is no rush. No need to run. Go treat the patient as AF. If it's regular, it could be what? It could be atrial flutter, or it could be AVNRT. So what you do is that you have to slow down the heartbeat. So what do? You can do vagal maneuvers. You can give adenosine. It's either aborts the tachycardia, which means mostly it was AVNRT, or it slows down the heartbeat. You can see the baseline looking like a sawtooth. You know it's atrial flutter. You can treat it as atrial flutter. Got it?
Yes, ma'am.
So one more time, when there is a narrow complex tachycardia, do not think, what is this? What is this? Don't do that. Why? Because when you do that, you see this, you say, what is this? It's AF. I'm telling you, this is AF. It's AF. So what to do in AF? The first thing that comes to your mind is beta blocker. And that is the wrong answer. Why? Because your patient is unstable. Blood pressure 77, patient dizzy. Okay, patient also has chest pain, I guess. So here's the thing. Don't do that. First question, always, Any tachycardia, even the broad complex tachycardia, patients with pulse, first question is that patient stable? If the patient is not stable, go directly for shock. Patient stable, yes. Now, regular or irregular? Done. Even for the broad complex is the same thing. The exact same questions. Got it?
Yes.
Yes? Very good. So here's your question. You have a narrow complex tachycardia. Okay. What is the first question? Patient stable or unstable? How's the patient?
Unstable.
Busy, unstable.
Unstable. What is the correct answer?
Synchronized.
Synchronized cardiology.
Easy peasy. Done.
So irrespective of what it is, if the patient has pulse, then it will be synchronized. If the patient doesn't have pulse, it will be a defibrillator.
Yes, but of course, not all the cases. I mean, if there is an indication to give cardioversion, if your patient has pulse, it's gonna be synchronized. If there is no pulse, unsynchronized. Got it?
Ma'am, for broad complex also it will be the same. I mean, for the
Broad
VT,
complex, believe me, broad complex is also the same, just some minor differences. What is the differences in broad complex? Broad complex is this. Let's say your patient has a broad complex tachycardia. Again, one more time, we're talking about patients with pulse. Patient without pulse, directly CPR. Broad complex tachycardia. What is going on? First question, patient stable or
Stable or
unstable?
unstable.
Right? This exactly the same adverse signs. Syncope, shock,
Chest pain.
chest pain or ischemia on ECG, acute heart failure. Fine. If it's that the patient has any of those considered unstable, you do seek expert help, you give the patient synchronized cardioversion. If your patient is stable, take a look. Is it regular or irregular? If it's irregular, do not touch the patient. Do not give amiodarone, don't do anything. Irregular broad complex tachycardia is dangerous. It's either polymorphic ventricular tachycardia, which you should not give amiodarone for, you should give magnesium, or it's AF plus bundle branch block, okay? Or AF plus Wolff-Parkinson White. Those are both dangerous combinations. We don't know. General practitioners, we don't know what to do with them, okay? Patient is stable. What matters is that patient is stable. So you just call the cardiologist. Seek expert help directly. Don't do anything else. The only thing you can do is just check the patient's electrolytes, okay? But if it's regular, it's most probably VT, ventricular tachycardia. Ventricular tachycardia with stable, patient stable, what do? You give the patient drugs. Amiodarone, lidocaine, procainamide, anything like that. Got it? Yes?
yes.
Very good. Next question.
Excuse me, ma'am, one doubt. You're saying like stable, irregular rhythm means you don't want to do anything? Like no
Irregular.
medications?
Irregular.
Irregular, no medication is needed.
No, nothing. Don't do anything. Just check the patient's electrolyte, call the cardiologist.
Oh, what if the rate is too much, like 200?
Okay, the rate, let's say the rate is 220. Patient is stable? Yes? What are
Yes.
you? Patient is stable. No chest pain, no acute heart failure, no ischemia and ECG, no syncope, no low blood pressure. Patient is sitting there talking to you. What are you worried about? So no rush. Check the electrolytes, call the cardiologist. I had a patient like that. I was in my emergency room. A nurse came to me. One of my nurses told, I have palpitation. We checked, heart rate was 180. We did the ECG, it was ventricular tachycardia. Patient, no pain, nothing. He was sitting there talking to us. So what did we do? Nothing. We called the cardiologist. Even it was because it was like, it was regular. But what did we do? Nothing, because patient was stable. Yeah, okay. So eventually we gave him amiodarone. We called the cardiologist. He went to CCU. If there is no adverse effects, it means the patient is stable, sitting there talking, everything normal, no chest pain, patient no unstable, blood pressure normal, everything normal. So what's the rush? Nothing. Got it?
Yes, ma'am.
There. Your patient is a 63-year-old who was brought to the emergency department by ambulance. He's being treated for an acute myocardial infarction. You are getting ready to start an IV, and he suddenly loses consciousness. You check his carotid pulse, find it to be weak and thread. It is too fast. You look at the monitor, it reveals a wide complex tachycardia. What do? Amiodarone, lidocaine, synchronized cardioversion, pacemaker.
Option C,
Mm.
synchronized cardioversion.
Anyone else have any idea? So it's the same thing. You have a broad complex tachycardia, right? With pulse, right? Guys, do you hear me?
Yes, ma'am.
Yes.
Very good.
Yes, ma'am.
Broad tachycardia with pulse. What is the first question?
Stable or unstable?
Patient stable or unstable? What is your patient? Stable or unstable?
Unstable.
Unstable.
What is the answer then?
Since pulse is there, it will be
Cardioversion.
synchronized cardioversion.
Exactly. Since pulse is there, it would be synchronized cardioversion. You seek expert help, you give synchronized cardioversion, you check the electrolytes, you give the patient amiodarone afterwards. But if the first thing is, just give the patient synchronized cardioversion. An elderly man is brought to the emergency department by his grandson. He's not responding, but he does have a faint carotid pulse. He does have a faint carotid pulse. Heart rate is estimated to be 150, blood pressure 50/24, skin is cool, pale, and damp. You request an ECG. This is the ECG. What is this? Second degree AV block, AV NRT, sinus bradycardia, monomorphic ventricular tachycardia.
It's ma'am D. Monomorphic VT. Am I audible?
Yes, yes, I'm waiting for other people to answer. First question, is it broad complex or narrow complex?
Broad complex.
Broad
Broad
complex.
complex. Very good. Sinus bradycardia, is it broad or narrow?
Narrow.
Narrow. When you say sinus, it means it's coming from above the ventricles. It's coming from the SA node. So it would be narrow complex unless you have a bundle branch block. AV node reinatory tachycardia, same, narrow complex. Second degree AV block doesn't mean anything in this question. Technically, you have a regular broad complex tachycardia. Most of the times that's a VT. Especially like this, no P waves, no T waves, nothing. Of course, it's VT. But anyway, fine. It doesn't matter what it is in the management of the patient. It's a broad complex tachycardia. What is the next question?
Stable
Stable
or
or unstable?
Stable or
Stable or unstable? How is the patient?
unstable.
Unstable. What do you do for this patient?
Synchronized
Synchronized.
synchronized.
Very good. A coworker comes in with a 48-year-old man who's complaining of chest pain. His heart rate is more than 176. He's lightheaded, worried about fainting. You assess the patient, ABCD, using the primary and secondary survey. You request an ECG. You are unsure what the rhythm is. The patient is deteriorating, heart rate is irregular and fast. You request a cardiology consult, alert the team. What is the most appropriate step to take? This one was the first ECG. This one was the time that it was regular. What is this?
Broad complex,
VT.
regular VT.
Yeah. Complex, regular, patient unstable. What would you do?
Synchronized.
Pulse
Shock.
is too synchronized. If pulse is
Yeah.
not there, then
Would do synchronized. Fine. Second, then after a while, it becomes irregular. What would you do?
same. If the patient is unstable, we go with the pulse. If the pulse is there, synchronized. If pulse is not there, unsynchronized. If the patient is stable, then we won't touch the patient.
Pulse is not there. If the pulse is there, fine. If the pulse is not there, you start CPR, you look what is the rhythm. Is it shockable or non-shockable? Got it? But by irregular, after VT, an irregular rhythm patient without pulse usually means VF in the
Yes.
question. So if you saw that VF, the answer would be unsynchronized.
Unsynchronized.
Asynchronous
Like-
shock.
Like this. So what is this?
Ventricular tachycardia.
Ventricular fibrillation. This is
Fibrillation.
irregular. What would you do for this patient?
Shock.
Shock. Defibrillation.
Fibrillation. Why don't you check the pulse?
Because next is the heart will stop pumping.
Yeah. Technically, VF patients, there is no pulse, never. If a VF patient has a pulse, it's either not VF or there is not a pulse, you are mistaken. There's no scenario in which a ventricular fibrillation patient has a pulse. So for these patients, you'd go directly for defibrillation. Because most cardiac arrests are the result of coronary artery disease, the post-arrest patient should be transported to a facility capable of PCI, emergent open heart surgery, neurosurgery, trauma evaluation.
PCA.
CI, ma'am?
Of course.
Ma'am, can you help with the shockable and the non-shockable?
Sure. Okay, so here's the thing. Let's say you have a pulseless patient. Let's go even further back. You have a collapsed patient. We don't even know yet whether your patient has a pulse or not. You see a patient collapsed. What do you do?
Check for pulse.
CPR compression first.
No,
Check for pulse. Carotid.
no, no. None of those.
Shock.
No,
Raise the feet.
no. Always the first step when you see a patient collapse is shout for help.
Okay.
If you're alone, call for help. Because doesn't matter what is the situation, you cannot be alone. If your patient doesn't have pulse, you can't do anything. You must have seen in this movies, in this medical TV series and like that, the second that the patient is too sick or collapses, the doctor usually shouts for help. I need a crash cart here. Okay, so that's the first thing you do. Shout for help or call for help. Then you check the signs of life. If there is pulse, okay, So what do? You just support the patient in whatever is the problem. Example, let's say there is pulse, there is no breathing. So what do? You do rescue breaths. There is breathing, there is pulse, but your patient is seizing. What do? You keep the patient position. You try to put the patient in a safe environment like that. But if there is no signs of life, means there is no pulse. What do? Pulseless patient.
CPR.
Start with CPR.
You call the resuscitation team. Even if you're in the hospital, the first thing to do is to call the resuscitation team, either you or have someone else do it. If you are outside, you see there is a patient with no pulse, do not start CPR first. First, call the ambulance, then do the CPR. At least you know that they're coming, right? Because what are you going to do alone without any shock, any oxygen, and nothing? How long are you going to go on doing the CPR? You can't even last 10 minutes alone. So you have to call the resuscitation team first, then start CPR. You know the CPR, 30 to 2 compressions. Then, whenever you have a monitor, you put the patient on the monitor. On the monitor, you have 2 general options. Either you see VF or VTAC, ventricular tachycardia. These are shockable rhythms, which means you give the shock, you continue doing the CPR. Anything else you see, and I'm telling you, you might see anything. Your patient pulse less, you might see anything. You might see a flat line. This is called asystole.
Asystole.
Or something that we call pulseless electrical activity, which means there is electrical activity, but there is no pulse. Example, it could show a normal sinus rhythm. It could show a VNRT. It could show AF, atrial flutter. Anything else, any kinds of block, doesn't matter, bradycardia, whatever. While there is no pulse, they are called pulseless electrical activity. There are some electrical activity, but there is no pulse, right? These are all non-shockable. So it's better to learn like this. If your patient doesn't have a pulse, you see VF and VTAC, do the shock. Anything else you see, no need for the shock. Got it?
Yes, ma'am.
Got it. That is shockable and non-shockable. Got it?
Ma'am, but SVT patient without pulse.
It's called PEA, pulseless electrical activity.
So we don't do defib for them.
No. No. Defib only VF, pulseless VTAC. Done. And we don't say pulseless VF because all the patients with VF are pulseless. So technically, defib only in CPR and only in the CPR in VF and VTAC. Otherwise, doesn't matter what do you see on the monitor, the answer is not defibrillation. Got it? Yes. Guys,
Yes.
did you
Yes,
get it?
ma'am.
Very good.
Yes.
Yes.
Thank you, everyone. This was your ECG session. I hope you liked it. Any questions, any problems, you can send me a text. Otherwise,
was
I'm gonna
wonderful,
see.
madam.
Oh, thank you, sir. Thank you. How are you?
I'm fine, thank you. Great.
Good that
So,
you're there.
no, I was learning ECG, your favorite class, so I could not afford to miss your class.
Thank you, sir. That's so nice of you. Thank you very
Wonderful.
much.
No, your ECG cardiology is wonderful. So people just give the feedback. I think she did her job excellent. I mean, she is one of the brilliant speakers. So I mean, it's worth to attend Dr. Maddy's class. So thank you very much, Maddy, for giving the good insight of the ECGs and make it very, very easily understandable. So thank you very much once again, guys, and join my mock test tomorrow as well. Those who get the time and chance. Thank you very much,
course.
Dr. Maddy. Thank you. Thank you very much. Yeah.
Thank
Thank
you,
you so much,
everyone.
ma'am.
It was my
Thank you very
pleasure.
much. Excellent, madam. Thank you very much. Thank you. Thank you.
Thank you, ma'am.
Of
Take care.
course.
Thank you.
Thank you, everyone. Have a good day and see you for
Thank
the
you.
next
Bye
segment.
bye.
Thank you.
Bye-bye.
Thank you.